So I'm going to talk about cervical cancer screening in 2014. We've heard a lot about the natural history, and we've talked already about HPV testing, so this will go over some of that again and be a bit of a replication. But if you've got a normal cervix, you get an HPV infection, and from that you can get cervical dysplasia. If you get cervical dysplasia, if that persists, you can get cervical cancer. We have opportunities for prevention along this pathway. The first one being preventing infection itself with HPV vaccination. We'll talk about HPV vaccination later on. The second is secondary prevention via screening, which is detecting cervical dysplasia prior to it becoming cervical cancer. And we know from this morning that there is a latency period for that, and we can pick up abnormal cells during that time and hopefully prevent cancer developing. One of the things you learn in medical school is the WHO criteria for a screening test, and these criteria should be met for a screening test to be implemented. This is the criteria from 1968, and they've been modified. And you can look at this, they'll be on the slide set for you, but the modified criteria are here. There's actually 10 of them, but it came out like this in my thing. So the screening program should respond to a recognized need. So there needs to be a problem there that you're going to detect to prevent. So cervical cancer is a problem. The objectives of the screening should be defined at the onset. There should be a defined target population. So in women, we should try to treat as much of the population as possible. There should be evidence of a screening program's effectiveness. So we need to know that it works. We do generally know that screening for cervical cancer works and has decreased cervical cancer incidence in many countries. The program should integrate education, testing, clinical service and program management. So education is an important part, and what you've heard about the JEDIS cervical cancer screening prevention program is that there is education part of that. There should be quality assurance and mechanisms to minimize potential risk of screening, i.e. the tests should be reproducible, they should be done in a safe manner, and there shouldn't be over-screening and over-treatment. The program should ensure informed choice, confidentiality, and respect for autonomy. The program should promote equity and access to screening for the entire target population, which means that we have to try and target the whole female population, and that is the challenge. Program evaluation should be planned from the outset. You should try and plan ahead and see how you're going to evaluate your program and how you're going to develop things. And the overall benefits of the screening should outweigh the harm. We do know that there are potential harms of screening. There's the psychological trauma of pap testing. There's the reproductive harm that we cause by removing pieces of the cervix and perhaps causing preterm delivery. So when we look at that, and when you're looking at for cervical screening options and opportunities, you have things such as visual inspection with acetic acid, VIA, or visual inspection with Lugol's villi. Cervical cytology, whether that be conventional or liquid-based, and HPV testing. The questions you have, if you've got all of these options, is when to start, when to end, how often, and which test are you going to use? And this changed and has changed very recently in many countries in the world. Visual inspection with acetic acid means putting a speculum in, looking at the cervix, seeing an aceto white area on the front of the cervix here. This is done with a naked eye, and then often treating that with Lugol's iodine. The classification could be negative, there's no uptake of acetic acid. It could be positive, or there could be an obvious cancer to be seen there when you inspect the cervix. The test performs well when it's been looked at. This is a study from Zimbabwe with a sensitivity of 77% and a specificity of 64%. This was more sensitive for detecting cancer, detecting CIN, than was pap test in this patient group. And that's not surprising, given that when you implement pap testing, you need to have a very good quality assurance scheme for pap testing. And if you're not doing a lot of paps, there's problems with that processing, how you take it, and how the cytologist reads it. That is one of the reasons for going to other methods. If you use cryotherapy post-treatment, you may be just cryotherapying everything that looks white if you're not taking a biopsy, and there's a risk of over-treatment. It is, however, unlikely to be associated with a adverse pregnancy outcome. There is a risk of under-treatment and missing things. I know in many provinces in Canada, they have essentially strongly discouraged the use of cryotherapy for treated dysplasia, and I don't do it in my practice. And you could also miss small cancers because there will be no biopsy done. A pap test has challenges. You need a nurse or a doctor to collect the specimen. The supplies are relatively low cost, but you need a cytologist to process and read the specimen, a pathologist to confirm. You need oversight of the lab with quality control because of the subjectivity of the test. It may take weeks to report. You then have to notify the woman, bring her back, counsel her, and then talk about other treatment. You then might need colposcopy, which we're obviously going to talk about a little more. And overall, it can be quite expensive to go through the whole process. So, where does cytology fail? It fails because of the mediocre sensitivity. Its sensitivity is around about 50-55% to detect high-grade dysplasia. And there are false negative cases, so that means the test has to be repeated frequently. It used to be that we had a mantra that everybody got a pap test every year. In Canada, we've gone to every 3 to 5 years. The patient has to be compliant. They have to come back for results, repeat tests, colposcopy, and it's sort of based on the cases. So in many countries there's been a long history of cytology, and cytology has caused a decrease in mortality from cervical cancer. You can see from this graph here. A big decrease in Denmark. Canada is the light blue in the background in the middle here. The UK is the green line here, or the khaki coloured line here that went along fairly high and then dropped in the mid-80s. Italy isn't on here. So we have a long history of cytology-based screening. It's been effective in reducing the burden of cervical cancer. In the UK, it really became effective round about here, where they introduced call and recall to the system. It's very labour-intensive. You need repetitive repeat testing, and it really needs an organised cervical screening program to be effective. One of the challenges in the USA, for example, is that there is no organised screening program. It's just up to the patient to come into the doctor, and there's very little organised programs bringing people back every 3 years to making sure they're having pap testing. That doesn't happen. Whereas in Europe, in the UK, Ireland, Scandinavian countries, in Italy, there is people being called and recalled into the system so they make sure they're getting their pap test on a regular basis. The compliance may not be very good with that, but it is improving. So we have to understand the limitations, and there's lots of limitations that have been quoted around. Cytology is not reproducible. The sensitivity is low. Even with optimized liquid-based cytology, the sensitive only goes up to about 75%. Colposcopy has its limitations in some studies. There's a little bit of argument how accurate colposcopy is. The Americans often argue, and some of these quotes are from the Americans here, that the credentials don't matter, but the number of biopsies does. I would argue that the training does, and the training is very important. There is arguments and difficulties about histology, and particularly less than CIN3 or low-grade change on histology. It may not be reproducible if you ask two pathologists the same question. There is also loss to follow-up in any program, and patients will have abnormal pap tests and you'll not know about them, and they'll go missing and they'll come back with a cancer. So you have to have a mechanism for calling people back. So some of the challenges we have in the West is the, as we, currently about 10% or 5%, 5 to 10% of Pap tests are abnormal. If we vaccinate people, we'll take that down and we'll have decreased lesion prevalence, and the patient, the cytologist, will only be seeing one abnormal slide every day. And that would probably be what is the case in Saudi Arabia. You'd have a low number of slides would be abnormal. So if the cytologist is only seeing one abnormal slide a day, they may not recognize an abnormality, or they may overcall it. So you might get false negatives, and you get further decline in the positive predictive value of cytology. Sorry, that was... Uh-oh. The specificity, the rareness of changes may suffer, and you might get, as the rate of abnormalities in the population goes down, you might get overcalling of cytology. So cytology has its problems, and in a medical legal environment they may overcall things, so you get a further decline in the positive predictive value of cytology. So if you look at this model here, women may have sex with a man who's got HPV, they may get an HPV infection, they may detect a persistent high-risk HPV infection, and a Pap test will detect this with low sensitivity, it won't pick up all of them. They may get persistence, and over several years they may get high-grade lesions, and the Pap test will detect this with moderate sensitivity, and then cancer may develop. So it picks up well when there's high-grade lesions there, but it doesn't pick up well when there's low-grade lesions there. If you compare this to HPV testing, it will detect both of these with high sensitivity, but will have a lower specificity. And we heard this morning about the advantages of HPV testing, and it picks up more abnormalities initially, and then allows you to examine those that are abnormal or at higher risk of having abnormal cells. So HPV testing, as we've heard, has already been implemented or being examined, and you can do serial HPV testing, as in you do cytology followed by an HPV testing to triage low-grade abnormalities such as ascus, and that's done in several Canadian provinces in Europe and in the USA. You could do HPV testing and cytology together, and the Americans do that, and they call that co-testing, where they would do a Pap test with an HPV test, and ideally do it every 5 years. It actually happens in the US, it gets done every year in a lot of women, so they're over-screened. Or you could do serial, as in they do an HPV test first, followed by cytological triage, and that's been examined in multiple studies, and particularly in British Columbia we have a trial, and there's a study in Italy and the UK, Scandinavian countries, and in Holland. So what are the current recommendations? And I put this slide up. This is the Canadian Task Force recommendations that were made, and what they suggested was, and they didn't feel that this, when they wrote this document last year, they didn't feel there was enough evidence to recommend HPV testing. So currently in Canada, we recommend that young women 19 or younger do not get routinely screened. The guideline that was written by a national organization said that women 20 to 24 shouldn't be screened, and then you should start screening every 3 years after age 25 and stop at age 70. What actually happens in practice is the provinces, the local areas, have their own guidelines because they look after this, and its screening starts at age 21 and Pap test done every 3 years, and that's with conventional cytology and no HPV testing at the present time. A lot of this changes in management was because of the harms, and the harms were in preterm delivery in a pregnancy after treatment for cervical dysplasia. And this is the forest plots from one of the papers from 2006 showing that preterm delivery was increased after treatment for cervical dysplasia, and preterm prom was also increased. Low birth weight was also increased. And that's, it seems to be conclusive evidence that all of the effects we do, the treatment we do, it causes increased incidence of preterm delivery in a subsequent pregnancy, although it may be that abnormal cells in CIN may increase the risk of preterm delivery. So in Canada, these fears and changes about harm cause screening to start at, on average, age 21 to 25, every 3 years, and age end 70. In the USA, their current guidelines say start at age 21, every 3 years to age 30, and then 5 years to every 5 years to age 70. They recommend cytology alone under 30, and then combine cytology and HPV testing every 5 years afterwards. In the UK, they start at age 25, every 3 years, and then every 5 years after age 30, and or slightly later in some areas, and cytology alone. Women who have had a hysterectomy for benign reasons and did not have abnormal cells do not need to have a pap test or screening. Again, we looked at the role of HPV testing. I note that the reference I've used this here is Dr. Cusick, and he's actually in Jeddah. Today we saw him, he's here for a breast cancer meeting. The role of HPV testing has been, we've talked about, is to triage equivocal low-grade smears and the follow-up of women with abnormal cytology but normal colposcopy to predict outcome after treatment of high-grade disease and enroll in primary screening. Dr. Sankarankaran did a beautiful study in India where they looked at 52 clusters of women in villages, and they were the first to show in this huge study with over 30,000 women in each arm. There's one arm that got HPV testing, one arm that got pap testing, one arm that got visual inspection with acetic acid, and one arm that just got some education about cervical cancer. They showed that the incidence of cancer greater than stage 1 was decreased in the women that got HPV testing, and the incidence of death was decreased in this group. So this was the first study conclusively show that HPV testing decreases the rate of death. This was in an Indian population, so it wasn't totally transferable to North America or Europe. And we've talked about this already, but the high sensitivity for CIN2, you identify all the cases of high-grade disease and you can lengthen the screening interval. It has lower specificity, so you might get more, if you just did an HPV test alone, you would get an awful lot of women coming into colposcopy who were false positives. They didn't actually have dysplasia on the cervix, so that's lower specificity. You need a second test to look at the triage for that. We are using pap testing for that at the moment, but it might be HPV genotyping or some other molecular markers. So HPV testing is objective, it's very sensitive, it has better quality control, it decreases the number of cytologists needed, avoids the situation of HPV negative low-grade findings, and it allows you to increase the screening interval. The disadvantages is that it may cause more people to come to colposcopy, and you need a second test due to the lower specificity. And the cytology, HPV positive cytology, I'm not sure what I was trying to say there. I'm going to skip over that one. So we need to work out on what the second test is going to be, whether it be HPV 16 or 18 testing, messenger RNA, E6 or E7, oncoprotein, or just using the test in a women over 30. There are different tests and rapid tests being developed by different areas that can be used in the third world, but most people would often use a gene hybrid capture test, which is the existing test we have here, and other competitors with that Roche have a test as well. This is just a picture of some of the rapid testing that Digene has. The other way to look at testing and screening, which may be applicable for Muslim women, is to use self-sampling. This has been well tried in numerous situations in Muslim groups and women in Europe, and you can use a pad, you can use a tampon, you can use a vaginal brush, a vaginal swab, lavage, or you can use a urine specimen. The further away from the cervix, the lower the sensitivity, but it does detect HPV, which allows you to do a next test. And often women can do this in their own home, and they wouldn't have to come into a hospital or a clinic to do it. So that may be a way forward. In studies looking for this self-sampling, one study from Canada, they had satisfactory samples, it was acceptable to the women, and about 70% sensitivity compared to biopsy. The specificity was quite high and was concordant with physician sampling. And if they looked at the different methods, the vaginal swab may be the best compromise. I just wanted to go over one study at the end. This is a study from November of 2003, and this is a European collection of 4 big randomized trials that Mario mentioned earlier, but was published in the Lancet. And what they looked at was 176,000 women from 4 studies using cancer as an endpoint. And they saw that invasive cancer was reduced by 60 to 70% over 6.5 years in the HPV testing group compared with cytology. There was no real change in the first 2 years, and this study, which is the amalgamation of previous studies together, is very important because it supports screening with HPV after age 30 with a 5-year interval, and so essentially that's what we've suggested for use here. So you may need to look at that and implement that. In low resource settings, you may need to tailor what you do, and you may need to do screening, either a see and treat single visit program with VIA, and there are some methods being developed using see and treat or using HPV testing on a one-stop test in the clinic. And there is evidence that a one-time screening around women at age 40 could reduce the chance of fatality due to cervical cancer by about 25 to 30%. So if you're going to do it once, you do it about age 40. And the most recommended and accessible method of treatment in low resource settings is the VIA. And often that is introduced in African countries, in Asia, as a method of actually creating some infrastructure and creating some clinics around cervical cancer screening, and then they could implement HPV testing later on, but there will still be a need for colposcopy in these settings. So the optimal testing may well be an HPV test at age 35, probably with a reflex pap test for an abnormality. If they're positive, they go for colposcopy. If it's negative, you repeat the pap test again in about 6 to 12 months. And if the test at 35 is negative, you could possibly rescreen at age 45 if you're looking at a way to bring people in and do that. So if we'd come here 10 years ago, we would have said pap testing was the way to go. It seems that HPV testing is the way to go, and the evidence that has really come together over the last year or so is that HPV testing is going to be the way forward in most organized programs. And if you're going to starting a program, you want to screen big numbers of the population, the best way to go is to HPV testing. The triage after the HPV testing has to be sorted out, and we have to decide where we're going to go with that. So I'm going to finish there.